Good evening, everyone. Thank you for joining us tonight for our latest medical sciences lecture titled AI, Smartphones and Lung Health, Breathless with Excitement. My name is India Dean Smith, and I'm a current medicine student here at UCL and your chair for today's event. In this lecture, Professor John Hurst and Dr. Luke Hale will discuss how smartphone sensors combined with AI can recognize real-time breathing and measure lung function. We encourage active participation, so please feel free to use the Q&A function on Zoom to submit your questions for our speakers. For those following on Twitter, the official event hashtag is hashtag FMS Lectures, and this lecture will be recorded, and a link to the recording will be sent out via email to all the attendees after the event. So before I introduce our speaker, we would like to know about our audience. So we're going to run a poll asking you to select the group you consider you belong to. So the choices are prospective students and their families, undergraduate students, PGT students, PGR students, PhD, academics, patients and carers, and any other. So I'll give a bit of time now for you to answer that question. So thank you so much to those that voted. So we've got some results here. 37% of you are prospective students and their families. That's 32 voters. 8% are undergraduate students. That's 7 voters. 6% are PGT students, and that's 5 voters. PGR students make up 5% of the voters, as 4 people. PhD students, there's 9, and that's 10% of the voters. There's 12%, which are academics, and that's 10 voters. And 7% are patient and carers, that's 6 voters. And 15% are any other, so that's 13 voters. So once again, thank you so much to those that have voted. I'm delighted to now introduce our speakers. We have John Hurst, Professor of Respiratory Medicine at UCL and an honorary consultant at the Royal Free Hospital. His research aims to find better ways to diagnose people living with long-term lung health problems, both here in the UK and overseas. And we also have Dr. Luke Hale, a surgical trainee and a visiting researcher at the UCL Division of Medicine. He is an NHS clinical entrepreneur and the founder of Peer Health. He is currently developing Lungi, a smartphone-based platform for asthma and COPD. Thank you, John and Luke, for joining us today. Now over to you.
Thank you very much, India, and a very warm welcome from here at UCL to this Faculty of Medical Sciences lecture. As you've heard, I'm Professor of Respiratory Medicine here, and I'm excited to talk about this topic tonight. But if we really want to understand how AI can transform lung health, we need to go back to basics. And we need to ask ourselves the question, how and why we breathe. And we need to understand just a little bit about what happens when the lung goes wrong. And to do that, I'm going to give away some of our trade secrets as a doctor about how we do our job. And then in terms of new solutions, I'm going to hand over to Luke to talk about that at the end of my presentation. But if you're ready, I want to know how excited you are. So we have a second poll, and if we can bring that up, I'd like you to tell me a little bit about how you feel about the potential for AI in health. So how excited are you about the potential for AI to transform healthcare? Very excited, a bit excited, not much excited, not at all excited. Not sure why you're on the webinar today. It's the last one. Maybe you're hoping to learn something new, but over to you to vote in this one. I will see where you are as an audience. So we'll just give you 30 seconds or so to do that. Fabulous. 61%, very, exclamation mark. 35%, a bit. That's 96% if my maths are right. So that's looking pretty good. 3%, not much. And one of you doesn't know. Well, hopefully we'll get to the bottom of that a little bit. So we can close the poll. Thank you for participating in that. So let's go on and let's start with some numbers. I don't know if you recognize these. You probably should. If it's a sort code to your bank, then I promise that's just a coincidence. What are these numbers? Well, we're all breathing 12 times every minute on average. We're all breathing 60 minutes in an hour, 24 hours in a day. And so that means that we're all breathing around 17,280 times a day. And aside, perhaps, from checking your phone, I'm struggling to think of much else that we do 17,280 times every day, which suggests that breathing must be pretty important. And breathing is important. But why? Well, it's all about energy, because everything we do needs energy. not just physical activity like the guy there on the left, but mental activity too. Even just sitting on this webinar and listening to me talking about energy requires energy. And all the background processes in the body that go on while we're asleep, well, they require energy too. And the body makes its energy in tiny factories within each cell called mitochondria. And you can see what they look like in the blue, in the middle. Every cell has them. And they make energy by burning fuel, often a sugar called glucose. So that's C6H12O6 on the screen there. And if we burn glucose with oxygen in these mitochondria, we make energy and we make some waste products. One of them is water and one of them is a waste gas. And that gas is carbon dioxide. So oxygen in and carbon dioxide out. And it's that process of getting the oxygen into the body and the carbon dioxide out of the body, we call it gas exchange, that's the function of the lung. Of course, when we're breathing in 17,280 times or so a day, it's not all clean, sterile air. It's full of things that might actually harm us. And that's one of the reasons why lung disease is quite common. Those things might be viruses, like coronavirus that causes COVID, for example, or pollution. And so our lungs also have a really important role in defending us from things that are potentially harmful. But getting back to the job of gas exchange, getting the oxygen in, getting the carbon dioxide out, that's done in tiny sacs right at the edge of the airway trees that are called alveoli, where the air and the blood are in incredibly close contact, making it easy for oxygen and carbon dioxide to transit between the blood and the environment. Now, we've got about 250 million of these alveoli in each of our lungs. 2 lungs, that's about 500 million alveoli. And if you were to calculate the surface area of all our alveoli, well, that's going to come somewhere close to half a tennis court folded up within our lungs. So this is an incredibly complicated structure. And to get the air down to where it's needed for gas exchange in the alveoli, we have to have a respiratory tract. It starts at the nose, the mouth, goes into the trachea. The trachea divides into 2 main airways, which divide and divide and divide and divide and divide about 20 times before we get right out as far as the alveoli, where the job of gas exchange is taking place. And it doesn't stop there, because to get the air in and out, we need a pump. The pump is our respiratory muscles, principally the diaphragm, but others too. And we need a control system. And that control system sits in the brain. It's automatic when we're asleep, but we can also affect how we breathe. And that control system is connected to the respiratory muscle by a series of nerves. For example, the phrenic nerve, which controls the diaphragm. And when any of that goes wrong, from the alveoli to the respiratory tract, to the respiratory muscles, to the control system, it's my job as a respiratory specialist doctor to find out what's gone wrong and to try and put it back together again. So how do I do that? How does a clinician make a diagnosis? Well, I sense I'm amongst friends here this evening, so I can probably give away a few of our secrets as a doctor. This isn't specific to respiratory medicine. This is true for any part of medicine. We start by asking our patients some questions. We call that taking a history. And as a respiratory specialist, I might be asking about respiratory symptoms like breathlessness, cough, and wheeze, and phlegm. And I might be asking about what that person is exposed to in their daily life, whether they smoke cigarettes, for example, or what kind of job that they do. Next thing that we would do would be to examine the patient, including listening to their lungs with my stethoscope. I have it here this evening, and it's on the screen in front of you too. And in addition to the history and examination, we conduct some tests. We call those investigations. And we put all that together. We put the story that the person is telling us, the history, with the examination findings, and with the tests to come up with a list of possible problems that that person has. A differential diagnosis is what we would call that. And what kind of tests can we do to work out whether your lungs are healthy or whether you have a problem with your lungs. Well, we've got three main groups of tests. Here's the first. We can test the function of the lung capacity tests, if you like, such as this one, which you can see on the screen here, which is called spirometry. In this case, the guy's doing the test sitting down, but we can also do these tests while people are exercising as well, if we think that it's an exercise-related breathlessness problem. In addition to looking at the structure, in addition to looking at the function of the lung, we can also look at the structure of the lung with scans like this. This is a CT scan, and lighting up on the left-hand side of that picture, you can see a very bright area. And that's a lung cancer, because this is a special kind of CT scan called a PET-CT, which shows us where there's activity within the body. So we have functional tests, and we have structural tests, and we have sampling tests. The picture on the right is taken down a thin, flexible telescope inside somebody's lungs, a test called a bronchoscopy. And that tiny set of tweezers that you can see coming into the picture, no more than a few millimeters across, is able to take samples of the lung away for analysis to try and tell us what's going wrong. Because there are lots of different ways in which the lung can go wrong, and there are lots of different lung conditions which I manage and look after as a respiratory specialist. Asthma is very common. For example, I have asthma, and it was World Asthma Day last Tuesday. But I want to talk a bit more about something that you might not be so familiar with. COPD, chronic obstructive pulmonary disease. COPD is very common, and at least here in the UK, it's principally caused by being exposed to tobacco smoke. Now, the risk of tobacco smoke goes way beyond the lungs, but it's the tar in the lungs. The tar is the black stuff that you can see over there on the left. It's the tar that causes the damage. But it's the nicotine in the cigarette that causes the addiction. And one way, clearly, to get people not to smoke is through tobacco control legislation. And you may have seen in the news just recently that the government has released plans suggesting that anybody who turns 15 years old this year or younger will never legally be allowed to be sold cigarettes. However, if someone is already smoking, then we have to think about other ways to help them quit that is safer for them than smoking. And perhaps vaping is one of the things that we might do, but vaping is very controversial because nobody knows the long-term harms of vaping. Nobody's been vaping long enough to do. And the real risk is that people are vaping who've never smoked in the first place. Now, why you would choose to put anything into your lungs that's not clean, fresh air, I just don't know. But some people can't choose what they breathe. Some people can't choose to breathe clean, fresh air. This photograph I took at one of our research sites in Peru. It's the home of an elderly couple, and they're subsistence farmers. And when we did their lung function tests, we found that she has COPD and he didn't, which raises the question is, what is she doing that he isn't? That means that she's got COPD and he doesn't. Well, here's another clue. These photographs not now from Peru, but photographs I took in India. And the problem is the same. The problem is indoor air pollution. Globally, that's as important as tobacco smoke exposure for causing COPD. Because about a third of the world cook and heat their homes by burning so-called biomass on traditional cook stoves. Biomass is crop waste. Biomass is animal dung. And that indoor air pollution in places like Peru and India is causing the same kind of lung condition, COPD, that in the UK would be caused by tobacco smoke exposure. So COPD is a huge problem globally, and it tracks with poverty, and it's often seen in women who, traditionally at least, have done most of the cooking and are spending most of the time indoors. Now, the diagnosis of COPD needs a lung function test, that test called spirometry, which I showed you earlier. The equipment is not that expensive. Just costs a few £100 for a basic spirometer. But of course, you need a healthcare professional who knows how to do the test and to be able to interpret the test. So the cost is not just about the equipment, it has to be used properly too. And in many settings, Peru and India, for example, or at least in many parts of those countries, this test isn't available. So how can we even begin to make a diagnosis of a lung problem when the diagnostic tests aren't available? And even here in the UK, it may be that I want to do those tests more often to see if my patients are stable or if they're getting worse. Well, that's not available either. We can't do these tests at home in a reliable way. So we need simpler tests, like the one that you can see on the right. That's called peak flow. But what we really need is a transformation in our ability to diagnose and manage people living with long-term lung health problems like asthma and COPD. So as I come to the end of my section, the introduction tells us that we need oxygen for energy and energy for everything we do. And for that reason, breathing is really important. Gas exchange is the job of the lungs. Lung disease is really very common. Please look after your lungs. They're very precious. But many people living with lung diseases don't know that they've got them. So we need better, newer, and more exciting solutions to lung health. And at that point, I'm going to hand over to Luke, who's going to tell you a little bit about what he's been doing in this space. I look forward to your questions later.
Hi, so sorry, I'll just share my screen. Okay. John, can you see that?
Yes, Luke, all good to go.
Yeah, great. Okay. So my name's Luke. I'm a surgical trainee in London, and a visiting researcher at UCL and the founder of a company called PIA. And I'm going to talk about some of the research that we've been doing recently, which is looking into ways that we can use the smartphone and artificial intelligence in those breathing problems that John talked about, so asthma and COPD. So why do we need new solutions? So John touched upon this, but one of the problems is that patients with breathing problems, that they're sometimes diagnosed very late. So they may have a breathing problem for a number of months or years, and they're not diagnosed. And this means that they don't get the treatment that they need, which means that they may be admitted to hospital unnecessarily. And it just puts added strain on the NHS. And this is really just a vicious cycle. So how can we break this cycle? And really, we need new solutions. So new ways to diagnose patients. And are there new ways that we can develop that would replace spirometers? And so spirometers, they work pretty well. They measure airflow, but there's problems with them. So they're not always accessible to the patients that need them. They're bulky, they're not always portable, and they're expensive. So they cost money to buy, they cost money to maintain, and they cost money to train staff to use them. Smartphones actually have some of the capabilities that we need to measure breathing function. So they have these very powerful sensors on them already. So things like your camera, the microphone, which usually we use for kind of taking videos on social media, but actually you can repurpose them and gather all that data and use it for something else, which we'll talk about. They're accessible. So most people have a smartphone, around 90% of people in the UK. You don't need to do any additional manufacturing. There's no kind of CO2 emissions, and they're already connected to a network. So you can share the data very easily. But how do we convert that smartphone data, so the camera data and the microphone data, to the breathing data, which is what we want? And the answer is using artificial intelligence. So what is artificial intelligence? So artificial intelligence is a huge subject. It's I'm only going to touch upon a tiny aspect of it. But generally, what we talk about when we talk about AI is things that a computer does that if a human did it, you would deem it to be intelligent. So things like reasoning, making decisions, and solving problems. And generally, what we talk about when we talk about AI is what's called neural networks. So I'll quickly go through neural networks and how we use them to potentially diagnose lung conditions. But these are some of the common uses of AI now. So things like object recognition in images and videos, language processing, so these large language models such as ChatGPT, and then more recently, things like very difficult problems, which are predicting the structures of proteins. And really, that's what we want to do. We want to take some data and make a prediction from it. So we want to try and predict the lung function of a person using that camera and microphone data. But how do we do that? So this is a very quick introduction to neural networks. So this is a neural network. It basically takes an input and transforms it to an output. And it's made up of these things called nodes or neurons. And these really just do quite simple mathematical operations, so things like multiplications, but they do them lots and lots of times in lots and lots of layers. And it transforms the data from one type to another. And then between these nodes, you have what's called weights. And these are really just numbers. And they determine how strong the output is from each one of these nodes. So as a very simple example, this neural network just determines whether this is a cat or a dog. And initially, we initialize the weights with just random numbers. And it's very unlikely that the neural network will get the answer right without further what's called training. So what we do is we show the neural network lots and lots of images of labeled data. And then after the neural network sees lots and lots of images, eventually it can recognize patterns. And then it can do a much better job at predicting what that input is. So in this case, it can correctly identify that an image contains a cat. But importantly, the neural network can also make predictions about data that it's never seen before. So you can show it an image that it's never seen, but it can still make the prediction. And it's this flexibility that makes neural networks so powerful. So what do we want to do? We want to take the smartphone data and we want to transform it into airflow data. So we want to basically measure at every single time step what the spirometry measurement is, which is the airflow. And we want to compare that to the smartphone data and try and match the two. So how do we gather the data? So we basically use the smartphone. So we use the camera and the microphone together and we gather the data. So this is measured from the smartphone. And you can see, so this is me doing what's called a peak flow maneuver, which is forcing out the air as fast as I can. And this shows the facial tracking data, the accelerometer, and the microphone all together. So you gather lots and lots of this data, and then you can train the model. So you compare what the smartphone data is, and you compare it to the spirometry data. And again, you change those weights so that the neural network can try and predict what the breathing flow is. So this is it's quite a early study. We're still gathering data at the moment, but you can see some early results here. And so the predicted blue line is what we're trying to get just from the smartphone data, and the target is the kind of ground truth, so the very accurate spirometry data. And you can see that they match fairly closely. They're within about 10-20%. But what are some of the limitations? We need lots more data, so we're gathering that at the moment. And at the moment, we've only trained this on healthy people, so healthy breathing function. And it may be that it doesn't translate so well to people with lung disease. And then there would be lots and lots more hurdles for this actually to be adopted in clinical practice. But how else could you use this breathing data? And something that we've developed is a platform that can use that breathing data and can use it to incentivize breathing exercises. So this is Lungy. So basically, as you breathe, the phone will respond in real time to your breathing. And I've just got a short video just showing Lungy in action. So that's Lungy. These are some of the visuals that respond as you breathe. So it uses the camera and the microphone together to recognize your breathing, and then you get real-time feedback. So hopefully, as you breathe, it's very kind of satisfying, enjoyable. And initially, we've released it as a wellness application. So breathing exercises seem to have benefits in two groups of patients. So patients with stress and anxiety, but then also potentially in pulmonary rehabilitation as well. And initially, we've launched as a wellness app, and it's available on the App Store at the moment. But initially, it's just for people with healthy lungs. So what we're doing for patients with asthma and COPD that John talked about. So we're trying to develop a platform that can integrate these breathing exercises, but then also other things that can improve the self-management of those conditions, so asthma and COPD. And hopefully we'll release it later this year. And this targets the second in the sequence. So it's really trying to get patients to self-manage their conditions as well as they possibly can. And it combines a number of quite small interventions that hopefully together will really improve the management of those breathing conditions. So things like breathing exercises, incentivizing physical activity, trying to get them to use their medication at the right time, and also kind of educating patients about their breathing condition. And so hopefully it'll be released later this year, and hopefully we'll start doing clinical trials early next year. So I'm just going to touch upon some of the limitations of AI in healthcare. It's obviously getting a huge amount of attention at the moment, and it is very exciting, but we have to be aware of some of the risks. And so one of the things that we came across in our study is that you just need so much data to train these neural networks and actually get a really good result from them. And it's sometimes quite tricky to get that data, especially in healthcare. Another thing that's very important to keep in mind is bias. So I've got an example in a second, but bias is really just making sure that the data that you put into the neural network and the data that you train with is representative of the population that you're trying to help. And it's very, very important that it accurately represents the population, because otherwise you can get kind of skewed results and it can't help, or it sort of discriminates against a certain group of patients. And the other thing to be aware of, especially with these large language models, is the sort of black box. You don't actually know how these models are coming up with their answers. They're so complicated, they're so huge, that we don't fully understand how they arrive at the kind of output that they bring out. And also kind of related is this hallucinations, which is generating output which is completely false. It doesn't exist in the training set, and we have to be very, very careful about how we interpret that, especially in healthcare. So this is an example of bias. So hopefully this is quite obvious that, so on the left, it's a picture of Barack Obama. And on the right, you can see the AI has enhanced his face. But because the training set is biased and probably weighted much more towards Caucasian males, it's enhanced him to be a Caucasian male. And this is a complete kind of misrepresentation, and it just shows some of the dangers of having bias in the training set. So we have to be always aware that this is a huge risk and a huge danger, especially in healthcare. So this is another example. So this is an MRI, and you can now feed this into a large language model, so such as ChatGPT, and you can get a diagnosis, which seems amazing. It seems very incredibly powerful. We can give the large language model MRI scan, and we can get a very convincing diagnosis. But actually, you may be able to see that actually this is not an MRI of a person, it's an MRI of a salmon. And there's at no point has the MRI, the AI mentioned that, and the report is very convincing and gives a very kind of thorough diagnosis, but it's completely useless. And it's another reason why we have to be so careful about what we put into these large AI models, and also how we interpret the output. So I'm just going to ask the question again, how everyone feels about artificial intelligence in medicine. Okay, I reckon that is enough time. Interesting. Has that changed much, John?
No, it's about the same, I think, Luke.
It's about the same. So whatever, yeah, it's sort of evened out, whatever happens. But yeah, interesting that it hasn't changed, I guess. And so these are just some of the sponsors of the study. It's still kind of ongoing. And this is Kagri. So he did a lot of the machine learning work, and Asthma and Lung UK. So they've been very, very helpful in involving asthma patients and COPD patients throughout the whole development of Lungy and the lung function testing as well. So thank you very much, and I'll be delighted to take any questions.
Great, thank you so much for such a fascinating lecture. We're now going to move on to the Q&A portion of the webinar. So if you use the Q&A function at the bottom of the screen, you can send in your questions, and I'll read them out. So we've already got some questions sent through. The first one is, does this mean if you have a log burner, you're at higher risk of COPD?
Yes, is a short answer to that. So whilst environmental exposure is not as significant a risk as the personal exposure that you might get from a lifetime of smoking cigarettes, yes, there is a small increased risk, and obviously something that's something that we're seeing increasingly commonly. Again, so making sure that stove is properly ventilated would be good.
Great, thank you. And our next question is, why is there such a rate of people being diagnosed or not presenting for diagnosis, especially thinking of parents and children?
So one of the amazing things about the lung is how much spare lung capacity we have. And so actually it's possible to lose quite a lot of lung function before that you know that you have a problem. So that's one reason. And it also depends on how physically active you are. So if you've always been a super active person, then it may well be that you notice smaller changes earlier because you aren't able to do all the really fit things that you were doing. Whereas if you're less physically active, it's possible that you might lose more lung function before realizing it. And that, of course, access to healthcare for all sorts of reasons over the past few years has been really difficult. And so people haven't been able to get access to the tests that they might otherwise have done. So it's a really important question. Thank you for it. And it's not an easy one to try and sort out, really.
Thank you. And our next question is for Luke. So how do you anticipate regulating the quality of data used for AI models in healthcare?
So, I mean, regulating it's whether the regulation at the researcher level, it's very important that you gather data and you really have to quite manually choose whether it's good. So if you feed your whatever the AI is rubbish data, then you're going to get a rubbish outcome. So you really have to sort of prune the data, make sure that what you're putting into it is representative of the population, that it's good quality. And by regulating at that stage, you can try and make sure that the outcome, the output from the model is good and valid. But the real crucial part of training these large models is the quality of the data that you put in. And you have to be very, very careful about the way that you gather the data and be very systematic about how you sort of select it and prune it as well.
Okay, thank you. And our next question is once again for Luke. So the question is, could you explain what weights are in a neural network again?
Yeah, sure. So I'll just share.
I'm glad you got that question, Luke, not me.
Yeah, I'll try and answer this. I should say, so I'm not a machine learning researcher, but I can answer some of these more basic AI questions. But so the weights in the model, they connect the nodes and they really determine how strong the sort of propagation of the signal is between those two nodes. And so if you had a very high weight, so usually the range is from 0 to 1. So if you had a high weight of 1, then it would mean all that signal gets through. If you had a weight of 0, then it would mean none of that signal gets through. And it's they're inspired by neurons in the brain. So this is what a neuron does in the brain. It sort of takes these inputs and then sends off outputs, but it sort of decides how strong that signal is and whether to send that signal sort of downstream. But yeah, neural networks is a huge topic, and yeah, we can't go into too much detail, unfortunately.
Thank you. Our next question is, what are common misconceptions people have about how to keep their lungs healthy?
But to be honest with you, I don't think we're used to thinking about lung health in the same way as we are perhaps about heart health. And so actually even getting people to think about lung health would be a start. I think in general, we're aware of the risks of smoking, but perhaps not some of the other things that we do. And vaping would be a really good example of that. We just scratched the surface of some of the issues around that today, but that's a very live debate. And you've heard the excellent question around wood burners. So people are doing things differently over time that might also increase their risk of disease. So having the conversation, that's one of the reasons that Luke and I were so pleased to be with you today, India, is to have this conversation in public about lung health, right? Because often it's not heard in the same way that perhaps some other conditions are.
Yeah, great, thank you. And our next question is, with the diagnostic usage of AI, how does the technology account for poor technique on part of the user?
Yeah, this is a very, very good question. And it's actually, I didn't talk about it much, but it's one of the hurdles that you would have to overcome for this to be adopted widely. It's one of the reasons that we use the camera input. So people have tried this with just the microphone, just with audio. But one of the problems is that you can't really tell what the patient is doing and whether the way they're using it is going to result in a valid result. So one of the reasons we use the camera input is that you can filter out some of those uses that aren't correct. But it's a very, very good question, because what you need to be very careful of is you need to determine whether the reading is low because someone didn't use it correctly, or whether the reading is low because their lung function is very impaired. And that's one of the real risks of using this technology, or just sort of giving this technology to a patient and for them using it to use it at home. And it will be a kind of tricky problem to solve, and there will be lots and lots of steps to solving that. And it's a really good question.
Just reflecting on that, so that's also relevant to spirometry, for example, because when we're doing a lung function test, we need the person to blow into that machine as hard as they can and as long as they can. Otherwise, we get a falsely low reading. And so the way that we get around that in clinical practice is to ask people to repeat the test. And we know that the test is the best test when we get repeatable results within a certain percentage difference between different attempts at the test. And so there's already examples of AI algorithms being used to support spirometry, to be able to say to the person who's doing the test, yes, this is good enough because it's within a certain limit, or not. But it's that repeatability which might be the answer to that. That's certainly how we do that in clinical practice. That's a great question too.
Great, thank you. And our next question is, what other lung diseases could this platform be potentially used for?
So I think, go ahead. No, go ahead.
So it's, in my mind, it's sort of like two parts of the platform. So there's like the diagnostic part, which is the spirometry measurement, which in theory, if it works, it could be used across lung conditions. And then there's the sort of pulmonary rehab part of it. And again, potentially that could be used across lots of lung conditions, but initially we're just targeting the two largest ones, which is asthma and COPD, and really just testing those groups of patients. I'm sure John will talk about, like, there's lots and lots of lung conditions, and they are quite different, and you may not be able to manage them with a single platform. So really you would develop the platform so that it would target each patient group individually.
And indeed, people living with asthma and COPD often have periods where they get worse, often driven by infection. We call those exacerbations, for example, and that might need extra medication. And so having a tool which helps someone to recognize when they were getting worse and helping them to know what to do when they got worse would be a really useful thing in clinical practice as well. So Luke's talked about the diagnostics. I think that's really powerful, but also monitoring and supporting people's self-management. And there are examples of these things which are out there as well. So I do think there's quite a lot of promise in this.
Thank you. And sort of linked to what you were talking about, John, our next question we've got is, would love to know your thoughts on how best to earn patients' trust in AI-enhanced healthcare, and what are some realistic and easy to implement applications of AI in primary care?
That's a great question. So I think AI, personally, as not an AI person, as a medic and as a human being, AI is here to stay. So we should use it, but we have to use it well. And that means knowing what it's good at. And it also means knowing what it's not good at. And Luke's shown you pictures of Barack Obama, which increasingly don't look like Barack Obama. And there are lots of examples of this recently in the news, right? So if we're going to use something, and we should use something, we just need to know how it's being used. And its strengths and weaknesses to be able to use it well. And I think there are all sorts of applications in primary care. So when we say primary care, we tend to mean family health in the community, GPs and district nurses and pharmacists and physicians, all these kind of people. And this is the front line of healthcare. And the challenge of being a GP and working in primary care is the challenge of being an expert in everything and dealing with risk. And so anything that can help support people to feel more secure in those diagnoses and management plans is a really good start for an AI application. How to build trust in it, that's the more difficult question, I think. And that comes with testing and retesting and testing in different environments. But that's no different perhaps from starting to trust any new technology that comes in.
Good, thank you. And our next question is, what do you think about the applicability of this technology in low and middle income countries and what the advantages would be?
What a great question that is. Thank you. And I can see that Fatima has asked a similar question in the chat there. Thank you for that. And there's a few similar ones to that. So the majority of people living with chronic lung disease live in low and middle income countries. How we support them to live better lives is a really live question. And I think someone was suggesting that not everybody will have access to a smartphone, and that may well be true, but maybe the clinician has an access to a smartphone and that smartphone is AI enabled. So it's not that everybody needs one of these things. It might just be that the healthcare worker in that setting, the community health worker has it. So I think there really are advantages and really exciting developments here. And actually, as you go around the world, you see the increasing use of smartphones in everyday life, or for example, for money transfer, for payments and other things. So the technology is evolving and becoming more and more widespread. And so the opportunities to use that for good in healthcare, when it's done carefully and properly, are huge.
Fantastic, thank you. And our next question is, could AI ever be used to fully diagnose an illness, especially within respiratory medicine?
Well, maybe that's a question for the audience next time, actually, a poll around that, whether you would prefer to see a real human doctor or whether you would prefer to see an AI doctor. And there already are examples of AI doctors out there. The WHO has got one, for example, called Clara, I think. And it's quite interesting to play around with these things. Doctors make mistakes, inevitably. And so just because something is artificial versus real doesn't mean that the doctor is always going to be better all the time. And that really raises an interesting question about what happens if the AI makes a mistake, and who is responsible for that when the AI makes a mistake. And so it comes back to this idea that, yes, we should be exploring these exciting technologies and using them, but we need to use them properly. There's no reason why AI can't make a diagnosis. But I think the idea to use the jargon, and there's a lot of jargon around here, keeping a human in the loop is a really important step, I think.
Thank you. And our next question is, does the quality of the camera and microphone of the phone affect the results? And will a newer phone provide more accurate results?
It's a very good question. So we designed the system so they could work with iPhone 6 and newer. So iPhone 6, I think, is about 10 years old now. We test across different phones. So we try and kind of even out all the variability between different phones by including them all in the data set. It shouldn't change the results, but we haven't looked at that specifically. But one of the things with Lungy, the breathing platform, is that we were very, very keen to make sure that all phones, all iPhones initially, are supported. So any iPhone on the market can run Lungy. It's very important that these platforms are accessible as possible. And we're kind of looking into Android, which is obviously a huge other group, and those two groups together represent most people with smartphones. So we are trying to make sure that all phones are supported, but there's obviously some tricky aspects to that, especially once you start trying to build for Android.
Great, thank you. And our next question is, thinking of Ella, what can individuals do about the impact of pollution beyond paying attention to the smog index?
So there was a young girl who's come to prominence because of the amazing work that her mother has done in relation to raising the awareness of asthma and asthma deaths and asthma challenges for young people. And I think that is partly coming back to what we were saying before about having the conversation and raising awareness. And this actually comes down, a lot of respiratory disease is associated with disadvantage across the life course, wherever you live and wherever you work. I work in Camden, North London, and the disparities that we see in Camden are huge. Some of the wealthiest parts of London and some of the most disadvantaged parts of London, just within a few miles of each other. And it's clear where the burden of respiratory disease is sitting, because it associates with poor housing, with air pollution, with cigarette smoke exposure, with mold, with dust, with all of these things. And so how do we begin to address these? This becomes not so much a problem in respiratory medicine, it becomes a public health problem, and that we need to tackle that at multiple levels, from primary legislation. So, for example, around air pollution initiatives, so traffic emissions, for example, there's an example, controversial, but something that may impact respiratory health. And we talked about the tobacco legislation and a whole generation, hopefully, of younger people going to be growing up smoke-free, right down to things that we can do individually. So the choices that we make every day can affect our health too. So that's a really good question, and that family deserves so much respect. I'm in awe of what they've achieved in the wake of a most unspeakable tragedy.
Thank you for your answer. And our next question is, can this tool currently replace spirometry or just be a screening tool?
No, it can't. Not right now. But what happens if you don't have any spirometry? So is this tool better than nothing? So that's a different question. That's not the question you asked. But we've been talking about the issues in terms of access to spirometry. And whilst if I have spirometry at the moment, spirometry is giving me an answer that I can understand and I can interpret. But everybody has access to that. And so hopefully, when we have bright young entrepreneurs like Luke working in collaboration with bright young AI engineers across the boundaries, so not just medicine, but medicine and engineering together, using stuff that's already in our phones that we weren't using in the first place, well, maybe, just maybe, amazing things are going to happen.
Fantastic. And our next question for Luke we've got is, first of all, thank you for developing Lungi. I find it really helpful and intuitive, while also still having a playful side of it. As a user experience designer myself, I'm curious about the ideation process behind the app. Specifically, how was your journey testing the different ideas with users? And how did you manage any potential clinical risks associated with the solutions?
It was quite a long development path. It probably took about two years. And yeah, I'm glad you like it. I'm glad you appreciate the kind of playful aspect of it, because that was very important as we were developing it. We want it to be like enjoyable to use, and it's something I felt was missing from a lot of healthcare apps. They're not actually that enjoyable to use by the patient, and it just means they don't use them. And it's something like 95% of health apps aren't used more than twice or something like that. It's quite shocking how little they're actually used. So one of the things is we wanted to keep testing with users and making sure that they understood how to use it. And it was the first time I've ever developed anything like this. And we should have involved users earlier. So we probably involved them about 6 months in, and you've already made a lot of decisions at that point. And as soon as you show someone, your whole opinion of the thing will completely change. And you have to be very brutal about taking things out that don't make sense. If it doesn't make sense to someone, then it's no good, and you have to kind of start again. So it's really like an iterative process, like a design process, and you're working with users really directly and just finding out what they want and what they understand. And because sometimes it might make sense to you when you develop it, but it may be completely like not make sense at all as soon as someone picks it up. The other question about risks. So Lungi as a wellness app, it's designed for people with healthy lungs. So we sort of flagged that up right at the start. So during onboarding, it kind of alerts you that you shouldn't use this if you have breathing problems. And then the pulmonary rehab platform is a much more a kind of higher regulated medical device. So we have to do a really formal risk assessment and really check against evidence and literature that anything in the app that could potentially have an kind of adverse effect any risk is reduced as much as possible.
Great, thank you very much. And our next question is, why specifically AI and not exploring a portable and accessible yet accurate substitute tool?
So why AI in the spirometry platform? Or
yes, I think instead of maybe a portable spirometry machine or a smaller version of the tool to.
Oh, so one of the reasons we didn't want to go down the kind of hardware route, so making another device, is that these devices exist. They cost money to manufacture, and it means you have to distribute them in some way. So you have to get them to the patient. If you can do everything just on the device, so on the smartphone, then you don't have to distribute anything. And it means that anyone with a smartphone can, in theory, access the technology. It just means that anyone can access it. It's more scalable, and potentially it could be used in kind of across the world without those difficult, tricky problems of manufacturing and distributing it everywhere.
Great, thank you. And our next question is, well, there is no actual measurement of airflow from the patient's mouth. Do you think that pretending to breathe can affect the result?
It's a good question. So it uses a combination of all the sensors on the phone. So pretending to breathe, it wouldn't cause the microphone signal. It wouldn't cause any microphone signal, so it wouldn't be interpreted as breathing. It's one of the reasons we want to combine all those sensors together. It's so that you can try and exclude those sort of false positives or things that seem like breathing but aren't, and you want to try and exclude all of those so that you're only left with sort of valid data, valid results.
Great. Well, thank you very much. And it looks like we're out of time, so we'll need to conclude here. But thank you all for joining us today. Before you go, we kindly request your feedback on today's session. So a survey will be sent to you shortly after the event, and we greatly appreciate your input. Many thanks to everyone who shared their comments and questions, and a special thank you to Professor Hurst and Dr. Hale for delivering an excellent lecture. Wishing you all a wonderful evening.
Bye, everybody.
Thank you. Bye.